restate some of the things I said earlier, because I think we have some different faces in the audience and we are recording these individually. So my name is Barbara Bass. I'm the VP for Health Affairs and the Dean of the School of Medicine and Health Sciences. Been in that role since January of 2020. And as you know, we are here to welcome you. We're delighted to have so many alumni with us here and online as well for what is a really special reunion for us, our bicentennial year. That means that we have a special Bicentennial Symposium here to celebrate that wonderful mark in our GW School of Medicine's and Health Sciences for the last 52 years history. I'm going to, just in a few minutes, introduce one of our new programs. So we've introduced over the course of this year, GW Med Talks. So we've had some really notable speakers come and do this, and they're kind of fun in that they're not core necessarily biomedical science or clinical management disease, but really those other things that impact our lives as physicians, as scientists, as educators, as community members. But before I introduce Dr. G, she prefers to be known, I just want to once again let people recall that this is our bicentennial. The university was founded in 1821. We followed 3 years later, took that long to get the additional piecework done, policy done. But that means that really for 200 years we have created, produced, enabled, delivered to society thousands upon thousands of physicians, and for the last 50 or so years, other healthcare professionals as well, PAs, doctors of physical therapy, occupational therapy, scientists, basic discovery scientists, and many others. It's really a remarkable institution with a long and distinguished history, as I hope some of you just heard from Professor Jack Ackman's presentation, which will also be available on the web shortly. And we are going to carry on with these kind of special events here in this beautiful facility on the George Washington University campus, our Jack Morton Auditorium. And I hope that you'll have a chance over the years to come to log on to some of these really notable programs that we have. Lots to celebrate as we begin our third century. But today, I'm going to come back to our present moment and introduce our very special guest speaker, who is actually well known and certainly very well raised here in our GW academic medical community. Dr. Geeta Nayyar is a globally recognized physician leader who's really stepped into some interesting roles in her time as a physician leader. She's a real innovator. She's a great communicator who has explored the introduction of new technology into healthcare writ large, and also has found her way into organizations and major corporations who, of course, have healthcare as part of their repertoires. She's really one of those people that blends health and business, technology in a really fascinating, wonderful way. She's a sought-after speaker and author of as the author of a book entitled "Dead Wrong: Diagnosing and Treating Healthcare's Misinformation Illness," a phenomenon that we've all become quite familiar with over the last since the time of the pandemic in particular. This is a best-selling book that's been noted as such on the bestseller list for the Wall Street Journal and the USA Today list. She's a frequent commentator and expert on CNBC, CNN, Fox, and other prominent media outlets. She serves as the Chief Medical Officer for Salesforce and for AT&T, among other healthcare-related executive roles. She's currently on the board of the American Telemedicine Association and is an advisor to the American Medical Association. Back to her GW roots, Dr. G earned her medical degree from the University of Miami Miller Medical School of Medicine rather. And she, as I just met her young daughter out there, she was interested in our accelerated BSMD program. Well, it turns out that that began with Dr. G's influence, who entered an accelerated program of that at Miami at the age of 17, so an early bloomer all along. After her graduating from medical school, she came here to GW, though, and trained in internal medicine and rheumatology, and also completed her Master's of Business Administration, one of the physicians that has incorporated that into their repertoire as a physician leader. She finished her training and then actually stayed in practice with our faculty for some period of time before she went on to other ventures. So please welcome me, help me welcome Dr. G. So thank you for being here with us. So I guess as we've just heard, you've had a sort of unusual pathway compared to many. And you know, if we wanted to sort of summarize it pretty quickly, you went to medical school and now you work for a phone company. How does that work, you know? What do you really do? And just tell us about your pathway and tell us about what your current repertoire is and how you're impacting health in this job.
You bet. Well, first of all, Dean, thank you so much for having me. Thank you to your team for making this easy. And if you'll also just join me in thanking my old department here. Dr. Katz is a former chairman of rheumatology. Dr. Momeni, my old fellow, and her young son Ryan is actually joining the medical school soon. And my daughter Sonia's in the back eating chips. So thank you to everyone for having me. As far as how I ended up working for the phone company, well, I will say that I went to medical school when I was very young to be a doctor and to be a rheumatologist. Ultimately, Dr. Katz actually took care of my mom, who has a very rare autoimmune disease, and actually saved her life and is in my book. So this is all very much a coming home moment for me. But in order to answer that question, if you'll allow me, since we're all family here, we're all GW family, I have to tell you about my family and how I got set on this journey. So Mom is a triple boarded doc. My parents went from India to the UK to the US. As you know, you have to do your residency 3 times, right? You have to do a residency every time. So Mom was an ophthalmologist in India. She did OBGYN in the UK, came to the US, did internal medicine, started a hem-onc fellowship, dropped out of fellowship because she had me, so the story goes. Dad is a double-boarded pulmonary ICU doc who's 82 years old, still rounds in the unit every day, and saw patients throughout the COVID pandemic, despite yours truly's advice. So when I called to tell my 2 South Asian immigrant parents who fought so hard to come to America and give me all these opportunities, that I was going to be the chief medical officer of AT&T, they were not impressed. They were not impressed because their question was, where are the patients? Where's the purpose? Why did you do all of this to then end up in a commercial sort of business? And I walked them through my reasoning. And my reasoning was really what happened to me here at GW when I was an internal medicine resident and then a rheumatology fellow. We were the epicenter for Allscripts. I don't know how many people were here there. Then Gotham, I don't know if you were here. Gotham's also here to support me. Thank you, Gotham. And I saw very quickly, Dean Bass, what the limits of paper were, right? When we think about data, communication, handwriting, right? All of those things. And I saw the promise of technology, right? It was the first time we were implementing an electronic health record. Allscripts was the one, at least at the MFA. And I understood very quickly what the promise was, right? In terms of telemedicine, communication, hopefully better patient care, data, analytics, predictive analytics, all the things we were promised, right? But I saw how poorly it was being executed, right? And the main thing I saw was that it was a lot of technology folks and a lot of business folks who really did not understand patients or healthcare delivery like you and I do, right? The way that we see patients, the way the workflow works, all the things we understand now, but this was all very new at the time. And so because of Dr. Katz's support, I was actually in my MBA program and my fellowship at the same time, and I also understood the business case. I also understood from a business perspective, coding, documentation, just all the things the EHR was supposed to help us do, right? But that they were getting it wrong in each and every way, and not just at GW, but at every institution, and we continue to see that today. And so a number of roles became available for someone like me, who was a physician, understood patient care, understood specialty care as well as primary care, but also could understand technology and business and sort of how to put all of those things together. And so for me, it was always about the patients. It was never not about the patients, but I understood that technology was going to be a huge influence on the way we delivered care and the way that we took care of patients at the bedside. And I know all of you already know the end of the story, which is we have a lot of work to do. But at the time, it was very new and it was very innovative. And so I took a risk, honestly, and rolled the dice and have never really looked back.
Tell us a little bit about that risk. What was that entry pathway, and
Sure.
who were your mentors and sponsors during that time as you entered into that new industry?
Sure. Well, I'll tell you that it wasn't a straight path because, like I said, I knew I wanted to be a doctor, then I knew I wanted to be a rheumatologist, and how the tech component came together was either being at the wrong place at the wrong time or the right place at the right time, depending how you look at it. But it wasn't a straight path. I just understood that there were so many newer influences that were going to get between the doctor and the patient. Whether that was technology, whether that was going to be policy, whether that was going to be regulatory liabilities as we think about the things that have happened with telehealth. I understood all of that very early. And to be really honest, it kind of pissed me off, right? Because I felt like, but the docs know this best, right? We as docs understand this best, and in many ways we are the voice of the patient, which is often not in the room. And so I felt that the biggest value I could bring would be to bring my understanding of clinical medicine and clinical delivery and patient care, but with a business background, with an understanding of outside influences. And so I kind of put together a little bit of my own internship, I would say. Our program director, who was here at the time, allowed me to do a policy internship on the Hill when I was in my residency. With Dr. Katz's support, I was able to do an MBA, which opened up a whole nother set of doors for me, but not because I knew I was going to do technology. I just knew that I needed a new set of skills, and I knew that I needed a new network, because the only people I really knew were doctors and scientists and public health professionals. And I did meet with a lot of resistance. As much as I had mentors of all ages and all genders that supported me, definitely from the medical community, it was very much well, you're wasting your academic career. And there's only two choices. Are you going to go into private practice, or are you going to go into academics? Those were the only two questions people really asked you when you were finishing your training. And so when my answer was, I don't really know, but I know that this is the only time I'll have to explore. And so GW really became a place where I could explore, because we did have everything, right? We had a medical school, we had a public health school, we were down the street from Congress. And so I very intentionally sought out different experiences. The policy one was one I was very excited about in the beginning. And then after I spent some time doing that, I was like, this is too slow and boring for me. So that's out, right? And spending time in the business school was great, but the technology piece really spoke to me, because I understood that that was going to have the most influence, I thought, on my generation of docs. And I think so far that remains to be the case.
Mm-hmm. So sort of technology as in the digitalization of healthcare. Tell us about, when you say technology, that's a lot of stuff, huh?
It's a lot of stuff.
So tell us a little more specifically about the technologies that you think are sort of front and center right now that are changing all of our lives as those who take care of patients, and enabling some things to be better. What are those technology forms that are most important right now? So,
Dean Bass, have you heard of AI? So I think the leading technology that we're all talking about is certainly AI, generative AI, large language models, all of these things, right? And I would say, with my technology hat on, I think it's thrilling and exciting to think about all of the inefficiencies in healthcare that we could throw at AI to make our lives simpler and better. But I also think it's very scary when we think about health equity, when we think about patient care and keeping the humanity in care. And so what I always say with any new technology, and to me AI is the one everyone wants to talk about, but it includes social media, it includes telemedicine, it includes getting the EHR right, because it's still not right, but it is basic infrastructure we have to deal with in today's environment. And so when I talk to I enjoy talking to doctors more than technologists, but unfortunately I talk to technologists more. And I will tell you that what I always say to them is, it's important to start with the problem we're trying to solve. And when you ask technologists, what is the problem? Well, they say, Dr. G, we got physician burnout, we got doctors and nurses, we don't have enough of them, and they're really expensive. we're all really expensive. So we want to build all this AI stuff to get rid of the docs and get rid of the nurses, right? Any technology conference you go to, this is what they're all focused on. And that's where I stop them, because you and I know that's the wrong problem to solve, right? The number one reason patients come to the doctor still today is because they trust all of you. Even in today's post-pandemic world where trust is a big issue in our industry, 93% of all patients still trust their doctor. But those same 93% of Americans, when you ask them what they think about the healthcare system, that number drops from 93% to 52%. Because in a post-pandemic world, today's consumer understands that the system is not built for their success, nor is it built for their doctor's success. And so they understand the doctor is the one who is going to be their quarterback and is going to work around that prior auth, work around the system to actually take care of them. And so when I talk to technologists, I bring this home and I say, listen, patients are going to wait in the waiting room. They're going to deal with the dysfunctional system because they trust their doc. But if you can automate all of that dysfunction in the background, right? All of the things like prior auth, clinical decision support, better diagnostics and therapeutics, if you think about the life science and med device space, AI is going to change the game in every way. But we need to do all of this with preserving the patient-doctor relationship. If we start with that as the problem, that's where we disrupt medicine and we disrupt care and we disrupt trust, right? And we saw a lot of that with the EHR. As much as AI is new and exciting, a lot of folks were excited about the EHR in the beginning because it had this promise, right? It had this promise of efficiency. But what happened? We stopped looking our patients in the eye, right? We'd ask them the question of, so it's an 8 out of 10? Is it like, is it constant? Is it dull, right? You all remember this, right? It's changed the bedside. And then it was so inefficient, we actually introduced a whole new business called the scribe service, right? So we now hired someone who is not a doctor or a nurse, brought them into an already cramped examining room, and now we got 3 people in the examining room, and we would say to our patients' faces, don't worry about that person. They're not a doctor, they're not a nurse, they're just here to write down everything that you say. Now tell me, how much do you drink? Tell me, are you sad? Are you depressed? Right? So we really disrupted healthcare the way we did technology to date. And I think the biggest opportunity with AI is that we don't do that, because this is a much more powerful technology. And we have to be mindful that we can either amplify our good habits or our bad habits. And you and I know what makes our patients wait in the waiting room has nothing to do with the clinical care. It's all of the back end. It's all of the back end. And it's not sexy to say that to technologists. That's never the problem they want to solve. But clinical decision support, documentation, these very, very simple things can also generate billions of dollars in savings. And so it's not a sexy answer, Dean Bass, but it is the truth. It is the truth.
So it sounds like actually doctors need to know a lot more about AI than we do. So
definitely.
And we often will hear just sort of the tip of the scary part or the inappropriate part of how AI is a disruptor. So what would you say are the top 3 that physicians and healthcare providers of other sorts need to know about AI? What can we anticipate AI is going to do for us? And how are we going to intersect with that in the coming years?
Sure. I think the first thing is we're all already being asked to do a lot with a little, right? We're living in tough economic times. We have a burnout problem. There's no question of that, right? 1 in 5 healthcare workers is leaving the industry never to come back, right? And so the answer is not to give our doctors more or to say, go take a course on AI, right? That's actually the opposite of what I would encourage. I would say that it's more important for you to raise your hand and be a part of whatever technology is happening at your hospital, your facility, your academic medical center, whatever CME you might be interested in taking. It is important to stay relevant, but also to take a leadership position. And this comes from everything we've learned from the EHR, right? Because so much of what has happened with technology today has largely happened to doctors and to nurses, right? And to the care team. It has not happened with clinical leadership. And I think the biggest thing that we need to take away is to communicate and convey and take a leadership role at whatever institution is looking to implement some of these technologies and explain the day in the life of what it's like at the bedside. What is it that patients actually want? What is it that drives revenues into the system? And then work with the folks that are the specialists, right? Let them know the AI, let them know the tech. The piece that they don't know is what everyone in this room knows. And that is arguably the most valuable piece because it's the disconnect between clinical delivery and technology that has largely disrupted care today. So it's actually a very simple thing, but when you ask the average doc, do they want to be on a committee? Do they want to make the time for this? The answer is most of the time, no, I don't have the time, right? And so finding the time, finding the leadership opportunities, being compensated for your time is also equally valuable and needs to be communicated and resonated. I'll tell you, I just spoke to the big medical group at Hackensack, and this really resonated with that team who said, you know, we just walk into the hospital and all of these new things get thrown at us. And so there has to be, and there always is, a pathway to executive leadership and communicating what are the actual problems that the staff has, but really taking an interest in making sure that your technology partners understand a day in your life is arguably the most important thing to keep in mind.
Yeah. So I guess we often hear that, you know, in terms of the money we spend on healthcare in the States, we are high spenders and maybe low return on investment at times. And obviously, whenever we add a new technology, it's expensive. So walk me through kind of the financial model of how do you embrace and effectively adopt something like AI into our practice, or not so much into practices, but into our healthcare systems? What's their quote, their approach going to mean for us?
Sure. You know, I think the first thing is to always have a crawl, walk, run approach, right? Where you get into trouble is when you go, you know, you jump all in and very early. I think it's very important to understand there's so much about this technology that looks incredibly promising and frankly seems to have limitless potential, but is also quite dangerous, and we're still learning it, right? The idea of hallucinations is very real. It's very real, and when you sometimes will query some of these technologies, the results seem so perfect, and unless you actually know the answer, you don't know that the technology is wrong, right? And I've played with many of these, and I have, you know, been in rooms with leaders from Microsoft and Google, and they will tell you the same thing, which is we don't actually know. We don't actually understand how it's coming to this conclusion. So I think understanding, having the humility to say this is new, that doesn't mean that you don't innovate. I think you push the limits of innovation, but you're not pointing it at patient care, right? Because that's the thing in medicine, the N of one. Because one hallucination, one wrong decision that's based on that technology can cost a life, can cost a kidney, can cost a liver, right? And so we don't have that flexibility that other industries do. And so I think understanding the crawl, walk, run approach, pointing the technology at things where there is affordability in making mistakes, and each and every time getting the buy-in, ultimately getting the buy-in from the end user, whether that's in a clinical environment, whether that's in the back end, and absolutely metrics as far as ROI deemed best, and being realistic about them. Will you realize the ROI in 3 years, 5 years, 2 weeks, right? Understanding when those revenues actually come in. And also, as we think about AI, everyone is worried about their job. Is this then going to cost certain staff their job? So understanding all of those dynamics and the culture in which you roll these technologies out and how you pivot and how you grow is critically important.
You know, when you think about what academic medicine brings to healthcare innovation and advances, you know, we always go back to the discovery science, to translation to the bedside, and finally to implementation writ large. And that's been a laborious process. You know, that's often a 10, 20, really. Discovery to bedside, often a 30-year process, still is. And obviously this is one that's like happening overnight and not necessarily within the boundaries of implementation, and that the rigor that we've used for some of the other innovations in translational science, which AI is a form of science. So how do we balance that in this? What's the role of industry and in creating these new products and very lucrative industry at times versus healthcare and that more rigorous discovery translation process when we're adopting really what could be a transformative technology?
You know, again, I think this is also part of how you recruit your staff and your faculty, right? Because in academic environments, the beauty of an academic environment is you do get to learn, you do get to grow, which you don't get to do in the commercial space. I also think it's important to have interesting partnerships in the space, right? If we look at some of the partnerships that are now happening in healthcare, whether they're retailers entering the space, big technology companies entering the space, half of the innovation you have to do, I think it has to be a hybrid between an academic environment and a commercial environment, because this is where the technology is being developed.
Right, exactly.
It's at Microsoft, it's in San Francisco, and so how do you create an ecosystem or an exchange where you have what an academic medical facility has along with what is in the commercial space. And they're so thirsty and hungry for it, Dean Bass. They're so thirsty and hungry for young minds who are interested in healthcare, not learning technology, and how you bring those together. There's an interesting study, not an AI study, but there's an interesting study right now that Stanford and Apple are doing. Stanford, you all know Stanford, right? Big academic research center. They have patients, they have docs, they have scientists, et cetera. They actually reached out to Apple and said, we have an interesting question we'd like your help answering. And what they asked them is they said, look, we've got a cohort of patients with AFib. And the way we treat AFib right now is we put them on anticoagulation therapy, which is one, expensive, but two, dangerous if you're walking your dog and you slip and fall, dangerous if you're playing a round of golf and you have an accident. So Stanford reached out to Apple and said, what if we gave everyone a watch? What if we gave everyone a watch and we could actually identify in real time when they had AFib and then put them on anticoags only at the time that it was necessary? And what they're finding in that study is that it's pretty compelling. It's pretty compelling, but the question is such an interesting question, right? That an academic medical center is reaching out to say, how do we give less medication and how do we actually prescribe a technology that also can do other stuff, not just that? And so I think those interesting research questions can also be answered and provocated in the academic space, and the commercial side is happy to answer that and explore that in partnership.
Yeah, creating those partnerships are really clearly very important, whether that be with, as we learned in the pandemic, with pharma and the whole clinical research infrastructure that we needed to develop those vaccines so effectively and to disseminate so quickly. Technology's just got that very accelerated pace relative to the old tools of discovery science and biological science and that we've traditionally linked with healthcare. So how well prepared do you think our physician workforce is for this kind of leadership, this kind of stepping in, this kind of technology assessment and adoption?
So you know what is interesting, so I still see patients at the University of Miami. I'm local to South Florida, and I think every year the medical students are smarter, quicker, faster, and if they don't have the answer, they can certainly get to it much faster than I can. I think we're only going to live in a more tech-forward consumer generation, a more tech-forward physician generation, and I feel really encouraged by that because they're digital natives. Right? I mean, my daughter is here. You don't have to explain anything to her. She just picks it up and figures it out, right? There's no training involved. And the technology is better in that regard because before you did have to get trained on it, right? But now you can open up a box and it's ready to go. It's so user-friendly. So I think it will naturally happen. Every generation is in a different place. I think that's also normal. And I think every industry is appreciating that, not just ours. But what I also feel excited by is when I see a lot of clinician founders. So when you look at the startup space, if you look at companies like Oshi Health, they're physician founders that have said, you know what, I've had enough. This isn't working, right? And I understand the technology enough that I'm going to start a company and I'm able to also fundraise because you have the credibility and you build the network. And so I think a lot of our solutions in healthcare will actually come from the clinical space. Now that it's not so unique and it is so ubiquitous, I also think we're living in an era where the consumer is happy to do these things, right? The consumer is happy to text with their doc. They're happy to set up a virtual visit. They're happy to wear a device that's monitoring everything. And that wasn't the case before, right? That simply wasn't the case. And we would just ask patients to come in and write down finger sticks, right? Now it's sort of understood, why wouldn't that be automated and why wouldn't I have all the numbers, doc, right? So I think it's all slowly changing, but I feel very encouraged when I see this new generation of docs coming up, and I don't think there's just not as big a barrier to entry, and the patients are right there with us saying, yeah, I want to share all my information all the time, and sometimes we have to say, it's TMI, I actually don't need to know that.
Yeah, we certainly see that in our students, for sure, and residents. They're brilliant and very, very much more comfortable with all of this than some older folks, huh? I'm going to ask if there's any questions that the audience would like to pose to Dr. G. Anybody have anything they'd like to ask about? Oh, yes, somebody's back got a hand.
Can you think of an anecdote or an insight that you had that helped Salesforce do something in a way that was better clinically?
I mean, I have to tell you everything I did during COVID. How much time do you got? Absolutely. So I was the chief medical officer at Salesforce during the height of the pandemic. I was hired at Salesforce to do what I always do, which is to build health tech products, work with product teams, work with clinicians out in the field, and bring them to market. However, during COVID, because it was COVID and everything was on fire, as everyone knows and appreciates, I actually got pulled in to do more of an HR function for that period of time, and so quickly became in charge of our public health response as a big employer taking care of 80,000 employees around the globe. So when I say globe, that's important because COVID was at a different place in every country. There were different things that were culturally appropriate and not. And to deploy all the things that we had to do, we actually created a technology once we had testing, once we had masking and vaccines, and I actually worked with the product teams and deployed a technology that allowed us to automate the function of going into the office and out of the office. And I mean, the number of clients that we helped through COVID, I mean, I don't even have the numbers, but it changed overnight what we were able to do. And it was exciting for me as a doc to be in the position to affect almost 100,000 people internally, but then externally, I mean, actually the state of Rhode Island, I mean, the governor there worked closely there at the time, helped them for their public health state response. But it was actually a very simple technology, but it just utilized everything we could. But I was the one who was able to connect all of that, because I understood the product and the tech, and I understood, like, well, what's going to happen when you're at home and you test positive? What do you do then, right? And so how do you connect that workflow? But there are a number of
That's
examples.
great, thank you.
Other questions? Oh, here we go. Down in the front row.
I was actually talking to an AI person at a local hospital here in town about what they're doing in their hospital system. So it was very fascinating to me because she was talking about ambient listening, that they're trying to incorporate that to make our lives easier. You know, certainly, as you said, the promise of the electronic medical systems has not really been realized. And, you know, as a practicing clinician, my notes always ties me down. You know, but there's other things out there. There's Heidi, Copilot, all these things, just like EMRs, you know, everyone was competing to get in that space. But how is a practicing clinician that's in a private practice without all the funds of, you know, people investigating these new systems, how are we supposed to adapt it but also stay compliant? And I see compliance as being a major issue.
Yeah, it's a great question. So first of all, what's interesting about the documentation space and sort of ambient AI technologies is it's actually just bringing us back to good old-fashioned dictation, right? It's amazing that after millions and billions of dollars were spent on EHRs, we've ultimately just trying to take it back to good old-fashioned dictation, right? Which we used to do at the hospital, and I used to love it. It was easy, right? So one, we finally figured that out. The technology industry has finally realized that, man, this whole computer thing, it's not working out, and docs need to be able to just, you know, speak and run. The technology is really expensive right now, right? So the best technologies out there, I'm particularly impressed with the Nuance technology. The DAX technology is phenomenal. But it's very expensive. An average private practice or small practice certainly could not afford it. What I would say is they're getting a run for their money. So there are a bunch of startups in the space now that are bringing the price point down. May not have all the bells and whistles, but you may not need all the bells and whistles, particularly if you're in a small practice. So the price point will come down. I have no doubt about that. It is simply a question of time. And as far as the compliance issues, you have to push that on the vendor, right? You've got to push that onto the vendor. You've got to push that onto the way you're doing just your documents, your legal reviews, et cetera. But there is always, as you know, there's always just the reality of things. I mean, how many of us text each other about patients in a non-HIPAA compliant way, right? So there's a reality of compliance, and then there is sort of legal, black and white compliance. So I would say that you have to go through that whole process, but it's more of a legal process than a technology process.
Thank you. Well, I think we have time for one more. I see a hand right there on the aisle, I think. Yes.
In my opinion, and most of my colleagues, there is no good EHR. There's only ones that are less bad. And what seems to happen
That's right.
is that some institution decides they're going to have an EHR. They bring in the tech people that are going to write it and get some basic information and maybe winnow it down to a couple. Then they get a list of what all the doctors want in the system, what all the nurses want in the system, and what the folks that keep track of all the data and costs and everything want in the system. And then they go back and write it in a way that gets all that in there, but in a very nonsensical, poorly connected way that just drives us crazy. Doctors need to write these EHRs. I'd like your opinion about that.
Sure. So I appreciate your sentiments. I agree with your sentiments. And whenever I am asked by a technologist, what is my favorite EHR, I say they are all equally terrible. So we are definitely on the same page. Unfortunately, millions of dollars have been invested, time has been invested. As you know, every big health system in particular is stuck with these technologies. And now it's about reverse engineering to try to get to efficiency. I do think ambient AI will be that inflection point, but we're certainly not there. The one EHR I will tell you that is very interesting, has anyone heard of Modernizing Medicine? So Modernizing Medicine is the only EHR company, and it's because the co-founder is a doc, is actually a dermatologist who happened to be seeing his billionaire patient, and he was complaining about the EHR, and basically Modernizing Medicine was born. Modernizing Medicine is a specialty outpatient EHR. They literally hire doctors to create, sitting next to coders, sitting next to the technologists, and they literally have a bunch of GI doctors who create the GI module. They have rheumatologists creating the rheumatology module. I mean, it's brilliant. It's brilliant and fascinating, but it is a very niche technology. It's meant, again, for the specialty space because largely primary care was already taken, and obviously Epic and Cerner are the big ones in the hospitals. But that is the only EHR company that I think has actually done it right, because they really took the time to invest in having doctors through every single process of the product, the development, the implementation, and ultimately the sale. So that is one that I would say is different, but I completely agree with you, and that's fundamentally the problem, and I think what we're talking about is how do we actually change that and ensure that every company is like Modernizing Medicine, or at least the implementation piece or the pieces that can be adjusted and more agile, and that's where your leadership comes into play.
Well, I want to thank you for coming back to GW and sharing this fascinating career you're in the midst of, and we really look forward to seeing what comes next. And
Thank you.
Thank you all for participating. I ask you to take a very brief break. Be back here at 3:15 for our final speaker, but thank you so much.
Thank you, Geeta. Thank you.